welcome. I'm Catherine Banwell, your host for today's webinar. Today's program is about how to actively engage in myeloma treatment decisions at every stage of your care. Before we get into the discussion, please remember that this program is not a substitute for seeking medical advice. Please refer to your healthcare team about what might be best for you. Well, let's meet our guest today. Joining us is Dr. Mark Schroeder. Dr. Schroeder, welcome. Would you please introduce yourself?
Yeah, hi, Catherine. Thanks for having me. I'm Dr. Mark Schroeder. I'm an associate professor of medicine at Washington University School of Medicine in St. Louis.
Thank you so much for taking the time out of your day to join us. As I mentioned, this webinar is about actively engaging in myeloma care decisions. So I'd like to start with this important question. Why is it essential for patients to play a role in their care and treatment decisions?
Yeah, I mean, patients should be actively involved in decisions with their doctor. As a physician, doctors are thinking about what's the best treatment for their disease or their cancer. And patients, I think, have a role in trying to guide the doctor in terms of what outcomes they're seeking from treatment. What is their lifestyle like that we could potentially guide treatment around? Patients have different goals. Sometimes in cancer, we're going for curative therapies. Sometimes we're not, and quality of life is more important. Having an actively engaged patient ensures that your doctor is trying to tailor treatment to you. The patient who's educated also helps to bring resources to their physician about, sometimes physicians may not know of all the clinical trials that are ongoing, or potentially, even therapies, but having a patient ask about certain studies or ask about certain therapies, it helps to open a conversation with your physician to discuss those and to kind of talk through, why it may or may not be a good idea for them in particular.
Yeah. Well, thank you. That helps guide us as we begin our conversation. As a patient, engaging in your care starts with understanding your diagnosis. So I'd like to go through some definitions. What is multiple myeloma?
Multiple myeloma is a blood cancer. It's a cancer in particular of a blood cell called a plasma cell. Everybody has normal plasma cells in their body. It's part of your immune system that responds to infections. They also are cells that respond to vaccinations. And when a plasma cell becomes a cancer, it often forms a cancer called multiple myeloma. And that cancer results oftentimes in damage to bones, low blood counts or anemia, potentially kidney problems, or possibly seeing high levels of calcium.
What about smoldering myeloma? What is that?
So smoldering myeloma is a stage that happens prior to the development of myeloma that's causing organ damage. I talked about the damage to bones, kidneys, blood cells. That is called the CRAB criteria. The C stands for calcium, the R renal, A anemia, and B bones. We define myeloma by having damage to one of those four essential systems. Smoldering myeloma can happen when we actually see plasma cells that look like myeloma, that look like cancer cells, but they're not causing the CRAB features of multiple myeloma. And there is a chance that sometimes that smoldering form of myeloma, it's not causing any damage, but it can evolve and change into myeloma.
Okay. What is MGUS?
MGUS is a stage that happens prior to smoldering myeloma. We know that MGUS, which stands for monoclonal gammopathy of undetermined significance, it's a mouthful. That's why we like to say MGUS. But it's a protein that can be detected in your blood. Sometimes that protein, it does not mean you have a cancer. We can detect proteins like that in blood in patients who have, say, autoimmune diseases, and they're at low levels. It's just an immune response. It's produced by those plasma cells that can be cancerous, but sometimes plasma cells grow because they're stimulated, they're overstimulated. And so that monoclonal protein of MGUS can be detected in the blood, but we don't see an increase in the number of cells in the bones that are classic for myeloma. But we know that about 1% of patients who have MGUS, every year 1% might progress on to develop multiple myeloma. So it's a risk factor. It's on the spectrum of disease from MGUS to smoldering myeloma to myeloma.
Okay. And how is asymptomatic myeloma monitored?
So asymptomatic patients, I would consider those are the patients that have smoldering myeloma. So they don't have the high calcium, the renal issues, anemia, or bone problems. And typically those patients are followed up about every 3 to 6 months, depending on where they fit in kind of that spectrum of MGUS to smoldering myeloma and myeloma. Sometimes patients who have clinically identified myeloma and it presents very heterogeneous, sometimes they may not have a lot of organ involvement or organ damage, and maybe they're frail, they're elderly, and it may be appropriate also to observe patients who actually have some of the findings of myeloma, but the disease doesn't seem to be as aggressive.
Let's talk about the different phases of therapy for myeloma, and I'm going to ask you for some more definitions. What is induction therapy?
Induction therapy is the first treatment that we're starting for myeloma. It's oftentimes a combination of a number of chemotherapies that our goal is to get control of the cancer quickly, so reduce the burden of the cancer in a patient's body. Oftentimes when patients present with myeloma, that's when the burden of cancer is the highest. So induction therapy is a combination often of 3 or 4 different drugs given over the course of about 3 to 4 months to treat the myeloma and get initial control.
What about consolidation therapy? What is that?
So after you've had a response to induction therapy, your oncologist might talk about, well, let's deepen that response. That's when we think about consolidation. So it's going to be most of the time is a change of therapy from the initial 3 or 4 drugs that you were treated for in the myeloma. And an example of consolidation would be going through a stem cell transplant or more chemotherapy after stem cell transplant. So that's a change in therapy, and it ends up deepening the response, killing more of the cancer.
And what about maintenance therapy?
So after you have gone through induction, you have control of the myeloma. We've deepened that response with consolidation. We know that myeloma is a cancer that tends to come back. And we know from experience that continuing some of the drugs that we used in induction at low doses are effective to try and prevent it from progressing or coming back, and it extends that period of time. And that's maintenance therapy. It's using some of the drugs we used to initially treat myeloma at lower doses to continue to suppress low levels of the cancer.
Okay. Thank you for that. There are a number of treatments for myeloma patients. Can you talk about the types that are available?
Yeah. So the classes there's lots of drugs approved for treating myeloma, but also recently approved. And we classify them into big categories. One of the categories is called immunomodulatory drugs. Those are drugs like Revlimid and pomalidomide, or even thalidomide, which was one of the first immunomodulatory drugs. Those are oral drugs that work on a specific pathway in the myeloma that lead to the myeloma cell dying. Another class of drugs are called proteasome inhibitors. Those include drugs like bortezomib or carfilzomib. Those drugs are often given under the skin or in the vein. And we know that they work really effectively on their own, but also when we combine them with an immunomodulatory drug like Revlimid or pomalidomide, the effect is even better. Another class is steroids. Steroids are kind of one of the first drugs used to treat this cancer, and steroids are effective at treating myeloma cells. Plasma cells are responsive to steroids. one of the first treatment regimens used to treat myeloma were traditional chemotherapies, and those are usually reserved for later on. You might think of traditional chemotherapy that causes hair loss, nausea, vomiting, low blood counts. Those, decades ago were used to treat myeloma, but now we have effective oral IV or injection under the skin that don't cause a lot of the traditional chemotherapy side effects, but are very effective at treating the myeloma. And then another major class of drugs are considered immunotherapies. So these are treatments that are engineered to either stimulate the immune system to go attack the myeloma, or maybe it's even using part of your own immune system to engineer it to go attack the myeloma. Examples of those are called bispecific antibodies, which kind of binds to the myeloma, but binds to an immune cell, brings them together, or a CAR T cell, which takes your own T cells, genetically modifies them to attack the cancer.
Mm-hmm. And there's also a bone marrow transplant. Is that right?
That's right. Yeah, I neglected. So bone marrow transplant has been around for a while in myeloma. And despite it being around for so long and really good therapies being approved for myeloma, it's still a standard treatment for myeloma. And bone marrow transplant in myeloma uses a traditional chemotherapy called melphalan that's associated with the chemotherapy side effects we talked about. But the advantage of bone marrow transplant is that it prolongs the time before the myeloma comes back and needs other treatments. And that's why we do it. It can be toxic, but it can prolong the time before a patient needs another line of therapy.
Mm-hmm. We know that everyone's diagnosis is different. So how do you determine a treatment plan for an individual patient?
So it depends in terms of the patient. Initially, I will evaluate patients and determine how fit they are. Is it a patient that I think is strong enough to undergo a stem cell transplant? Is that going to be of benefit to them? That's not necessarily a factor of just age, but it's also, are they doing well functionally? Or do they have any other medical problems like heart disease or kidney problems? Those things play into my decision on treatment initially with patients. So whether you're fit or unfit will help to guide what your treatment's going to be. In general, fit patients are somebody that could undergo multiple treatments, go through a transplant, have minimal toxicity, and recover fully after more intensive treatments, whereas unfit may need more assistance, and we tend to reduce the intensity of treatments. Doesn't mean the treatments, if you're unfit, are less effective. They can be very effective, but our goals for treatment change in that situation. And we're looking for responses, but also looking for quality of life. And then it changes also depending on the genetics of the myeloma. Our treatment for patients who have genetic changes that are high risk will change compared to those that have what are called standard risk genetic changes. So that's an important point to discuss with your oncologist. If you have, do I have standard risk or high risk genetic changes in my cancer, and does that affect my treatment? And then also treatment in somebody who's being treated a second time or a third time or beyond for their myeloma depends on what treatments you had before and how effective they were, and what were your toxicities or side effects from those treatments. So all those factors play into a decision of treatment for an individual.
Yeah, oh, that's great information. Let's discuss what happens after treatment. How is the effectiveness of a treatment monitored?
When you're initially diagnosed with myeloma, we will perform testing of blood. We look for that monoclonal protein, or protein in the blood that's produced by the cancer cells. That protein level will be used to monitor the response of the cancer, and that's a blood test. That's called a serum protein electrophoresis. Also, initially, we'll have x-rays of the bones, or it might be a CT scan or MRI or a PET scan that's used to document, is there any bone damage? And oftentimes when we're following up, we follow the blood work to look for reduction in that protein level. We may follow up additional x-rays to see if there's new areas in the bones that are damaged, or if prior areas have responded to the treatment. And then oftentimes a bone marrow biopsy is used to document if you are in a complete remission, which means that the protein we detected before or the cancer cells in the bone marrow cannot be detected after treatment.
Why is it essential for patients to share any symptoms or issues they may be having with their healthcare team during and after treatment?
Yeah, I mean, the treatments for multiple myeloma, they are typically continued in patients. And as we continue these treatments, side effects happen. And as a physician, we can support patients through side effects. It may be as simple as adding a medicine to help with nausea. It may be maybe modifying the dose of the treatments. So it's important to kind of monitor for things like I'm having a rash or diarrhea, or I am getting nausea, and letting us know right away. What the bad outcome would be if a patient is taking a medicine, doesn't let us know about side effects and decides to stop the medicine. Obviously, if you're not taking a chemotherapy medicine, it's not going to be effective to treat your cancer. That happens sometimes. So having a good communication with your physician and your team of medical providers is important so that we can modify treatment. There are lots of alternatives or adjustments in the treatment that can be made that can be just as effective as the treatment you started on.
So communication is key.
Yes, for sure. Yeah.
If treatment is successful, then when is a patient considered in remission, and what does remission mean?
Remission, there are gradients of remission in myeloma. And we can have a partial remission, which means we killed about half of the cancer cells. We can have very good partial remissions, or we can have complete remissions. And those equate to the depth of response, or how well the myeloma responded. Those are measured by blood work, bone marrow biopsy, and maybe repeat imaging or x-rays. So if you have a complete remission, that means we can't detect that protein in the blood that was detected before, or a protein that was detected in the urine, and we can't detect the cancer cells on a bone marrow biopsy. We know that the deeper your remission or response to treatment, that equates typically with a longer time before the cancer may come back or need other therapies. Myeloma is a type of cancer that tends to come back. So we have very effective therapies, and sometimes these therapies can get the myeloma to a state that we can't detect 1 in a million cancer cells, but it tends to come back. And so complete remissions means that, yes, it's a good chance that the myeloma is not going to come back for years for you, but you still need to be monitored. You're not necessarily cured of the cancer.
Mm-hmm. Yeah. Unfortunately, relapse can occur after treatment, as you've been talking about. And sometimes a patient's disease doesn't respond to therapy, and that's called refractory disease. What are the indicators that a patient's disease may have relapsed?
Yeah, so we would typically be following a patient about every 3 months, somebody that's gone through the initial induction, consolidation, maybe they're on maintenance therapy, or maybe they're on active therapy for after they've relapsed from the myeloma. Each of those visits every 3 months, we're monitoring blood work, we're monitoring the monoclonal protein that the myeloma produces, or if it doesn't produce much of that protein, we're monitoring other parameters, say urine testing, or maybe even imaging like a PET scan. And we're looking for consistent rises in that number. And we're looking for not necessarily a little rise in the protein, but incremental continuous rise. That suggests that the myeloma is starting to grow again, and it's growing on the current treatment, and we need to switch gears and try a different treatment. There are some patients who that protein, the myeloma cancer doesn't die to treatments. That's refractory. So we try a treatment and there's just no response. We don't see a drop in the protein in the blood. We still see a good burden of the myeloma in the bone marrow biopsy. In those patients, then that's also an indication to try a different treatment.
Mm-hmm. You mentioned that myeloma often returns. So how typical is it for a patient to relapse?
Yeah, I would say that's the norm for patients with myeloma. There are reports in patients who undergo things like stem cell transplant that maybe 10% of patients might be out 10 years without detection of their myeloma, but that's not the norm. So most patients who are diagnosed with myeloma will go through periods of treatment and hopefully periods of remission. The majority go into periods of remission in the myeloma where it's not very active, but the myeloma tends to come back.
If a person is relapsed or refractory, how are they typically treated?
So when they relapse, it depends on their prior treatment. So if the myeloma is not responding to a drug, then it's from the physician's perspective that's treating you, a good idea to change the type of chemotherapy drug that you're on. Anytime, whether it's diagnosis or relapse, clinical trials are appropriate to engage with and potentially even use as primary treatment. All clinical studies in myeloma or for cancers in general are typically engineered around active treatments for the cancer. And so those studies in myeloma, when you're having the cancer relapse, say early in the course of your cancer, those studies typically are geared to use drugs that are approved by the FDA. Later in the lines of treatment, maybe you've had to progress to after 4 lines of treatment, but trying to move them earlier. And they're very active in the 4th line. So you could potentially have access to an active treatment moved earlier in the treatment through a clinical trial. There's also a long list of other approved myeloma therapies. There's a good handout, I think, through the NCCN for patients for myeloma that lists a lot of the approved myeloma therapies and kind of guides patients. It's a good resource book that I would point any of the listeners to.
Oh, it's a great idea. Thank you for that. What about emerging therapies for myeloma? What approaches are showing promise?
So I think that the biggest news in myeloma and across a lot of cancers now are immunotherapies. We know in myeloma now we have 2 CAR T cells. Now, a CAR T cell is engineering your own immune cell called a T cell to express a receptor on its surface that binds to the myeloma, and then those immune cells go and kill the myeloma. That's a form of immunotherapy. There's 2 approved CAR T cells for treating myeloma after the myelomas come back 4 times as needed for treatments. Those are very active in that line of therapy. And we can see response rates over 80% in patients who otherwise weren't responding to other approved therapies for myeloma. On the other hand, there's other immunotherapies that are used earlier in the treatment course of myeloma. One that's now incorporated more frequently for the initial treatment is a drug called daratumumab. It's an antibody. It's a protein that binds to the surface of myeloma and stimulates the immune system to react against the myeloma. And so it's not a traditional chemotherapy, but it's using your own immune system to attack the cancer. And then a third one that's probably looks just as potentially effective as CAR T cells are called bispecific antibodies. And that would use a protein similar to daratumumab, which is an antibody, but it uses parts of antibodies to bind to. It could be 2 different proteins, one expressed on a T cell, the other one expressed on the myeloma cells. And when it binds, it brings those 2 cells together and causes your own immune system to attack the myeloma. Those are also very effective. And within the next month or 2, there will be a bispecific antibody approved for treating patients with myeloma.
Oh, that's great news.
Yeah.
Any others?
Yeah, well, I mean, the other potential, there's other immune cells called natural killer cells that are also in clinical trials for development to attack myeloma and potentially even engineering those natural killer cells to attack myeloma. There are other antibodies. Sometimes the antibodies, a protein binds a specific target on the surface of the myeloma. I mentioned one daratumumab, but there's a whole list of others that are in clinical development. The one other antibody or couple other antibodies that are approved for treating myeloma are isatuximab, which also binds to CD38, and then another one called elotuzumab, which binds to a protein called CS1 or SLAMF7 on the surface of myeloma. That's more information than you probably wanted or needed, but those antibody therapies can be very effective in treating myeloma. There's another antibody therapy that has a payload of a toxin on the antibody, and it binds to BCMA or B cell maturation antigen. That's the same antigen that the bispecific antibodies as well as the CAR T cells are targeting on myeloma surface. And so that's potentially one that's approved by the FDA also to treat myeloma.
Good. Let's go to some audience questions. Penn community member Mark sent in this question prior to the program. When is the right time for a clinical trial? When everything else is refractory?
No, I think clinical trials should be, you should engage your oncologist to talk about clinical trials right from the beginning. We typically think about clinical studies. They could be either interventional, where we're actually giving a treatment. Some clinical trials are observational, where we're trying to learn about disease course in response to traditional therapies. Either of those may have direct benefit to the patient, or maybe it doesn't affect the patient, but it affects future patients with myeloma. There are clinical studies, like I mentioned, that are moving therapies that are approved, but they're approved after patients have been treated 4 or 5 times for their myeloma, and they're now being moved earlier in the treatment. Some of those are at the initial treatment of myeloma in that induction phase. And so we think that maybe by using some of these newer therapies or that immunotherapy class earlier on in the treatment of myeloma could result in deeper responses. We don't know if it's going to result in cures or that long remission beyond 5 or 10 years. But that's the hope. If we can move the therapies earlier and prevent the cancer from becoming resistant to multiple treatments, maybe we can lead to longer remissions and longer survival of cancer patients. So engage with your oncologist from the beginning through all of your treatment lines about clinical trials is what I would say.
Well, how can patients find out about clinical trials and what might be right for them? Where should they start?
I mean, starting with your physician and having that conversation is a good start. But there are resources for patients. The Multiple Myeloma Research Foundation, MMRF, has good resources. There's a called Myeloma Crowd that also has resources for patients with myeloma and social support for patients with myeloma to try and find it and match you with the clinical trial. And then if you're really academic and interested in doing your own homework online, all clinical studies in the United States, even internationally, are registered on a website called clinicaltrials.gov. Clinicaltrials.gov it can be searched. So you can search for myeloma, you can search for a specific drug. That will tell you where are the studies being done. Who are the study personnel? Who should I contact to find out about the study? Unfortunately, not everybody can travel for treatment for their myeloma. And the best chance of potentially participating in a research study is to initially talk with your oncologist about it. There may be a larger center nearby that you can visit to consider clinical trials. Clinical trials that are trying to, use the new immunotherapies would be a great option, but they may not be offered in, say, a community oncology practice. You have to have the infrastructure to conduct those studies. And if you have the resources to be able to travel, then finding something on clinicaltrials.gov. And I've had patients do the, legwork and talk with their local oncologist and get referred to a center that actually has a study that they're interested in participating. But a lot of times studies are going to have you visit the center for all of the screening tests and all the procedures for study.
Right. So you have to know that you have the time available as well as
Right.
the resources.
And the resources to do it. Yeah.
Yeah. Trevor had this question, Dr. Schroeder. My myeloma is considered high risk. What treatment options are available to me? And are there clinical trials specifically for high risk disease?
Yeah, great question. High risk myeloma happens in about a quarter of patients. So 1 in 4 patients will have high risk myeloma at the diagnosis. And it's important because we know that when we say high risk, that means that the myeloma is going to potentially come back sooner after treatments. It doesn't mean that the treatment that you're going to be given is less effective, but it has a higher propensity to come back sooner. Those patients with high-risk myeloma still benefit from a lot of treatments that we have for myeloma, but there are clinical trials geared to try and increase treatment in patients with high-risk myeloma to try to change the fact that their cancer comes back sooner than somebody who doesn't have the high-risk features by using novel chemotherapies or novel drugs to try to improve responses. So there are for sure clinical studies either at, potentially at initial diagnosis or at the time of relapse that could be entertained for patients with high-risk myeloma. And I would encourage you to, seek those out for sure.
Yeah. All right. Thank you. And please continue to send in your questions to question@powerfulpatients.org, and we'll work to get them answered on future programs. As we close out our conversation, Dr. Schroeder, I wanted to get your take on the future of myeloma. What makes you hopeful?
Well, I am hopeful. Just within the last, 5 years, there have been a number of new drugs approved for myeloma. They're approved for later lines of therapy, but they're being moved earlier in the treatment. And within the last 10, 20 years, we've seen an improvement in the survival of patients with myeloma. As these new therapies are in development, as they're being moved earlier in the treatment line, I'm very hopeful that survival and potentially cure for this cancer is possible. The only way that we're going to get to that point is through clinical research and for patients to partner with their physicians and to consider clinical trials, because that's the only way that new drugs get approved and are available to other patients with myeloma. So I'm excited about what is approved. I'm excited about what's coming through the pipeline to treat myeloma.
Dr. Schroeder, thank you so much for taking the time to join us today.
You're welcome, Catherine. It was a pleasure.
And thank you to all of our partners. To learn more about myeloma and to access tools to help you become a proactive patient, visit powerfulpatients.org. I'm Catherine Banwell. Thanks for joining us today.